Bismillah ar-Rahman ar-Rahim. This lecture is about anesthesia for single ventricle. Examples of single ventricle are many. First of all, what is the definition of a single ventricle? You may assume that a single ventricle is the congenital anomaly in which there is only one ventricle, like a rudimentary left ventricle, or a rudimentary right ventricle, or an absent interventricular septum, or a very large VSD, so that the two chambers are fused into one chamber. So this is the single ventricle pathology. But no, these pathologies are one of the pathologies that are called single ventricle. So a single ventricle is not only the pathology in which there is one ventricle. A single ventricle is a pathology, is a congenital heart disease that is uncorrectable surgically. So this is the definition. A single ventricle is a congenital anomaly that is non-repairable, in which two ventricle repair is not possible, whether temporary or permanently. So either now I cannot repair the heart, or but I can repair it later, or I cannot repair the heart anyway. So single ventricle. So examples of single ventricle are rudimentary LV or RV, mitral or tricuspid atresia, pulmonary atresia. This is an example of a temporary. The pulmonary atresia may be temporary because early in life, during infancy, we may manage as a single ventricle, but later we may replace the pulmonary or put a graft or something. So later we may correct the heart, but in these examples, the heart is non-repairable. A two ventricular repair is not possible. But in some examples of those, it is possible, either later, now or later. Hypoplastic left heart syndrome, double inlet left ventricle, straddling of the septal leaflet of the tricuspid valve through a VSD. So this is a simple case of VSD, but there is a cord from the septal leaflet of the tricuspid valve that passes through the ventricle, the VSD, and is inserted on the left side, in the left ventricle. This renders the heart non-repairable because this cord cannot be cut off. If we cut this cord, acute severe tricuspid regurg will result, and we cannot displace the cord because the cord coming from the septum, from the septal leaflet, eventually is connected to a papillary muscle. So I cannot separate the papillary muscle from the heart and insert it in another place. It is part of the myocardium and part of the system. So it's an entire system. I cannot replace it. These cases are managed as a single ventricle. Excessively complex procedures like TGE plus a common AV canal plus a pulmonary stenosis. So this complex procedure, sometimes it is not possible. Maybe we are in a center that cannot do this operation. The surgeons are not experienced enough to do it, or otherwise the patient will not tolerate such a long bypass with all these corrections. So we take the path of the single ventricle, either permanently or till the patient is transferred to another place that is capable of doing this complex surgery. The case is too complex for the hospital or the surgeon. The patient is too small, so we wait till the baby grows so that the surgery is possible, or the total repair is the two ventricle repair is possible. This is the algorithm that we follow. At birth, we check the saturation. There are two parameters that we rely on in the management of these patients. Adequate saturation for the patient to survive, and balanced QPQS. So a balanced QPQS should be 1:1, and the saturation should be high enough for the patient to be able to survive, to thrive, to grow, to be able to survive. So these two conditions we take into consideration when managing these patients. So we try as hard as we can to keep the QPQS 1:1, because a low QPQS would render the patient cyanotic, and a very high QPQS would congest the lung, causing congestive heart failure, and then later pulmonary hypertension develops. So we should balance the QPQS. Sometimes it is not possible to keep a saturation of 100% and the QPQS 1:1, so we compromise. We try to lower the saturation so that we can keep the QPQS 1:1. So at birth, we check the saturation. Of course, the best saturation is 100%, but in cases of single ventricle, especially with patients with the total mixing, like rudimentary LV and RV, like mitral tricuspid atresia, like DILV, these cases in which there is total mixing between the systemic and venous systemic venous return and the pulmonary venous return. In these cases, what do you expect the optimum saturation to be? It is not less than 75. This is cyanosis. This is not acceptable, and also 100% is not acceptable. So, if a baby is born with a total mixing lesion and the saturation is 100%, I should not be happy, because 100% in these cases indicates a very high QPQS, causing lung congestion and then later pulmonary hypertension, and the development of pulmonary hypertension in a single ventricle pathology is disastrous. We'll talk about this later, but these patients should not by any means develop pulmonary hypertension. So the best saturation for these patients is 85. 85 indicates that there is a balanced QPQS 1:1, because blood coming from the lungs is 100%. The saturation of blood coming from the lung is 100%, and the saturation coming from the body should be 70%. So if the amount of blood coming from the lungs and equals the amount of blood coming from the lungs, and they get mixed inside the heart, so the average results a saturation of 85% would be an average between 170. So this indicates a balanced QPQS, and this saturation is not too low to cause the problems of cyanosis for the patient. So the patient can tolerate this saturation, the 80s, and can live with it. So if the patient is born with a saturation of 85, so this is balanced, so we leave him without management till he grows. If the saturation is 100%, we put a pulmonary artery band to limit the flow to the lungs, to balance the QPQS. And if the patient is cyanosed, we try to increase the pulmonary flow by a PDA stent or an MBT shunt till the saturation reaches 85. So in a pulmonary artery band, we narrow the band till the saturation reaches 85, and in the PDS stent and MBT shunt, we raise the saturation to be 85, not higher and not lower. Then we wait for 6 months with a saturation of 85 in cases of total mixing. Some cases are like this, the straddling of septal leaflet of tricuspid valve. This is a left to right shunt, so it is expected for the saturation to be 100%. We may put a band just to balance the QPQS, so that there is no left to right shunt or there is a bidirectional shunt, so the saturation may remain high, not necessarily 85. But I'm talking about cases with a total mixing. So we wait to the age of 6 months, and then we do a Glenn operation. We'll talk in details about the Glenn operation, and we'll see. And this slide we'll see at the end of this lecture, this part of the lecture, to be able to understand it better. But at the age of 6 months, we do a Glenn operation, in which we connect the superior vena cava to the pulmonary arteries. And then at adolescence, after the growth spurt, we would expect the saturation to fall from around 90s to a range of cyanosis. Then we do a Fontan operation, which is a completion Fontan operation. We connect the IVC to the pulmonary, so eventually the SVC and the IVC are connected to the pulmonaries, and this should give a saturation of 100%. And then later, after 30 to 40 years, the patient may develop the Fontan pathology. Pulmonary artery banding. Preoperatively, the patient is congested, tachypneic, poor feeding, stunted growth. On diuretics, we check the electrolytes, because we may have a hypokalemia, hypomagnesemia, so they may need to be corrected. Make sure that the lungs are in their optimum conditions to avoid desaturation caused by pulmonary edema or pneumonia that may interfere with saturation assessment after banding. As we said before, if I find the saturation 100%, I put the pulmonary artery band and I tighten it to give me a saturation of 85. If the lungs are in a bad condition, for whatever reason, so I may reach this saturation due to lung issues. So after the lung issues resolve post-operatively, the saturation may rise again to be 100%. So the operation, I may discover that I have done little, and that the operation was futile. So we try as much as possible to optimize the lung condition so that the saturation reflects shunting and not the lung condition. So we eliminate the factor of the lung from the assessment. Intraoperatively, we insert an arterial line, a central venous line. We put a femoral. We avoid the superior vena cava, because later the superior vena cava will be used for the Glenn procedure. So I try to avoid inserting any lines in the superior vena cava, the internal jugulars and superior vena cava. Avoid deep anesthesia, not to interfere with hemodynamics, to be able to assess properly the saturation under conditions close to being awake. FI2 should be between 0.3 to 0.5. Theoretically, the FI2 should be room air, because we are assessing the saturation in room air. But an anesthetized patient with an open chest would have a mismatching between the ventilation and circulation. So we raise the FI2 a little, up to 0.5, to compensate for this matching. So an FI2 of 0.3 to 0.5 may mimic the FI2 of 0.21 for an awake patient. We should keep the PCO2 around normal. TE may be used. Surgically, it is a median sternotomy. Pulmonary artery band placement. We target a saturation between 75 to 85 on an FI2 less than 0.5. A needle is placed distal to the band to measure the pulmonary artery pressure after the banding. Pulmonary artery pressure is measured targeting the lowest pressure possible to give the target saturation. Optimize the lung condition, good ventilation, suctioning, recruitment, bronchodilators, furosemide if the lung is congested. ABG after more than 5 minutes of stable conditions to confirm the pulse oximeter. So we should not rely on the pulse oximeter in these cases, because the reading of the pulse oximeter may be in error. So we should be sure of the final saturation before closing the patient and transferring to ICU with an ABG. Peak gradient across the band around 36. After banding, the systemic blood pressure increases. We expect the blood pressure to rise because more blood will flow to the systemic circulation rather than the pulmonary. On-table extubation is usually possible, but sometimes they prefer the patient to, especially very young patients, to be transferred with an open chest to the ICU, so that they may later tighten the band or loosen the band in the ICU if the conditions change or if the lung conditions change. For the PDE stenting, the patients are usually neonates with a PDE, severely cyanotic and sometimes debilitated, with acidosis, acute renal failure, and impending arrest, because they are usually these neonates are PDE dependent, and the PDE is closing after birth due to the exposure to atmospheric air, due to exposure to the oxygen in the atmosphere. So the PDE closes by itself while the patient is dependent on it. So usually these cases are critical. These patients are usually on prostaglandin E1, Prostan, and adrenaline and fluids to increase blood flow in the pulmonaries through the PDE. Ventilated on room air or at most 0.35 FiO2, because any higher may help in further closure of the PDE. Difficult IV access due to young age and prostaglandin infusion that causes edema. Prostaglandin causes edema, causes apnea. We should expect apnea in these patients, so intubation may be necessary. May cause tissue edema, hypovolemia, fever. So we should expect in these patients on prostaglandin these side effects. Intraoperative, it is a procedure done in the cath lab. So in the cath lab, we continue resuscitating the patient till they open till they insert the stent. The operator may request a right internal carotid artery sheath, to be inserted by us, the anesthesia, or by surgical cut down, because the internal carotid artery access would be easier to reach the PDE, easier than the femoral, because the catheter coming, or the wire coming from the femoral artery would need a U-turn. We need to turn 180 degrees almost to reach the PDE. But a wire coming from above, from the head, from the internal carotid artery, would be directed more easily and more straight to the PDE. If unable to insert an arterial access, request frequent ABGs or VBGs from the operator. Inserting wires, catheters, or the stent itself inside the PDE before applying the stent may compromise the patient more due to partial obstruction of the flow, and the patient may easily arrest. So these patients are usually critical with a minimal flow across the PDE, and this minimal flow is what keeping the patient alive. So if we put catheter, wires, catheters inside the PDE before inserting the stent or the balloon or whatever, so the patient may collapse. So we should expect this. Post-procedure, we can raise the FI2 as needed. Heparin is needed to avoid closure of the stent by a clot, transferring to the ICU intubated. The MBT shunt, it is indicated for cyanotic patients who are not candidate for Glenn shunt, either due to a very young age, less than 6 months, or high pulmonary vascular resistance. We'll talk about this later. It leads to rapid development of pulmonary hypertension because I'm perfusing the lungs with the aortic pressure. And this pulmonary hypertension renders cavopulmonary shunts impossible. So if the patient develops pulmonary hypertension, Glenn and Fontan shunts are not possible. That's why it's very important to prevent the development of pulmonary hypertension in cases of a single ventricle. So the MBT shunt is either temporary or palliative. So it should not be a definitive treatment. It should be either temporary till the patient grows old enough to do a Glenn shunt, or palliative in cases of already developed irreversible pulmonary hypertension and the saturation is very low. So I put a shunt to increase the saturation and to give the patient a better quality of life till he develops Eisenmenger syndrome shortly. These are the modifications or the history of the shunts. The classical Blalock-Taussig shunt was an anastomosis between the subclavian artery and the pulmonary. It got replaced with a synthetic graft, background graft between the two arteries. In the past, they used these central shunts, but these central shunts causes more pulmonary flow, so the patient is congested more with faster development of pulmonary hypertension. So these shunts are not preferable now. They give a pathology similar to the truncus arteriosus, so they are not preferred. They found that this position is optimal. It is not too close to the heart and not too far from the heart, so it gives good perfusion with enough caliber to the lungs to be perfused, and at the same time it is not too close to the heart to cause over shunting. So they found that this position is optimal between the subclavian artery and one of the pulmonary branches, one of the two pulmonary branches, left or right. Preoperative, the patients are cyanosed with high hematocrit, compensatory hematocrit, and polycythemia. Some patients are PDE dependent and are on prostaglandin E1 with FI2 less than 0.35 and noradrenaline. Optimize the lung condition to avoid desaturation of pulmonary cause. Surgically, it is a median sternotomy with or without bypass. Intraoperative, blood available in OR for any injury of the vessels. Arterial line not on the side of the shunt, because an arterial line in this example, if I insert an arterial line in the right radial artery, and then I insert this MBT shunt, these sutures may narrow the subclavian artery. Also, the steel from the subclavian artery to the pulmonaries may render the readings in the right radial artery lower than reality, or lower than the systemic blood pressure. So we should not insert an arterial line on the side of the shunt. Avoid central venous line in the superior vena cava to preserve it for the Glenn shunt later. If done without bypass, during clamping of the subclavian artery, the blood pressure may rise. During clamping of the right pulmonary or left pulmonary artery, desaturation may get worse, and the patient may be severely decompromised and in a pre-arrest condition requiring resuscitation with shots of inotropes like adrenaline and vasopressors like noradrenaline and 100% oxygen. Because if I clamp the right pulmonary artery or the left pulmonary artery, mismatching increases dramatically in an already cyanotic patient, so this may render the patient pre-arrest. At clamp off, the ideal saturation should be around 85. If the saturation is too low, we should increase the size of the shunt. This is an under-shunting condition. If the saturation is too high, around 100%, this is an over-shunting condition, so the patient becomes congested and requires diuretics, and pulmonary hypertension develops quickly. Hyperdynamic, low diastolic blood pressure that may compromise the coronaries, so we should check the ECG, especially if the diastolic pressure is too low. Keep high diastolic pressure for coronary perfusion. Good filling. We keep the high diastolic pressure by good filling by vasopressors. Low FiO2, as low as possible to keep the pulmonary vascular resistance high. Permissive hypercapnia to keep pulmonary vascular resistance high. We put a PEEP and avoid bradycardia. Keep high systemic blood pressure for the pulmonary perfusion, because now the lung perfusion is dependent on the systemic blood pressure. So in these cases, we manage the lungs as we manage the kidney, that are dependent on filling and blood pressure for perfusion. If done on bypass, half or full protamine to reverse the heparin. We may give half protamine to avoid clot formation in the stent. Then later heparin infusion according to hemostatic situation. So we give half or full protamine, and then we wait till the surgeon confirms that the bleeding condition is fine. Then we start heparin infusion. Postoperative usually requires diuretics, monitoring for myocardial ischemia due to low diastolic blood pressure, requires heparin infusion and later aspirin. So postoperative hemorrhage is common, because if I start heparin infusion or aspirin, bleeding may appear later after starting these drugs. Shunt thrombosis and desaturation may occur, requiring urgent reopening and shunt revision. Superior cavopulmonary anastomosis, which is called Glenn shunt. It is we separate the superior vena cava from the heart and suture it to the pulmonaries. So blood flows from the upper body to the pulmonary circulation by gravity or by filling. The blood falls into the lungs without the presence of a pump in between, like the right ventricle. So blood flows into the lung. So it is very important for the patient to be filled, not to be dehydrated, so as to allow the blood to flow to the lungs. It is very important that the pulmonary vascular resistance is not high, because there is no RV to hypertrophy to resist the pulmonary vascular resistance and push the blood forcibly against this resistance. No, in these cases, if there is any resistance here, the blood stops and stagnates, and the patient desaturates and develops superior vena cava syndrome, edema in the head and the brain and the upper body and the arms. It is also important that the suture lines are not narrow, that this connection is wide open, and also the patient is mostly upright in position, either sitting or walking. That's why, as we have said before, we wait for 6 months, because after initial management, to give a saturation of after the initial management after birth, to give a saturation of 85, we wait to 6 months. Why 6 months? Because 6 months is the milestone for sitting. So these children are able to sit, so gravity will help in the gland flow. Okay, so preoperatively most patients are older than 3 months, so that the neonatal pulmonary hypertension subsides and the patient starts to sit up and uses gravity to aid superior vena cava drainage. At 6 months, the superior vena cava venous return is 60 to 70% of the total venous return of the body. Hemodynamic study is done in the cath lab to check the pulmonary artery pressure. This is important. So usually these patients have already undergone a hemodynamic study in the cath lab, ideally less than 16 millimeter mercury, and pulmonary vascular resistance is low. Check the saturation, check hematocrit level, ensure good hydration to avoid desaturation and thromboembolic events. Patients with an MBT shunt may be on aspirin or heparin, so we should take these into consideration. Surgery, either the first surgery to be done or redo after MBT shunt or pulmonary artery band. So we may expect these patients to be a redo, done on bypass with no cross clamp, unless other procedures are done, like pulmonary artery augmentation if the pulmonary arteries are narrow or stenotic, or atrial septectomy if the PFO is small. So I may open the atrium, the interatrial septum, for better mixing. Usually the pulmonary valve is closed unless 1.5 ventricle repair, pulsatile gland, is done. Cases of Epstein anomaly or mild RV hypertrophy. So usually we transect the pulmonary artery so that the pumping of the blood from the heart does not increase the pressure in the pulmonary circulation that may hinder the drainage of the gland. But sometimes in 1.5 repair we keep the forward flow, and these cases are not cases of a single ventricle, but rather cases of RV diastolic failure, like in Epstein anomaly. So we unload the right ventricle by doing a gland shunt. So I unload the venous return from the upper body, so that the right ventricle receives only blood coming from the lower body. In cases of Epstein anomaly or mild RV hypoplasia, a bilateral gland is done in cases of bilateral non-communicating superior vena cavas, left and right superior vena cavas that are not communicated with a large bridging vein. So to be able to drain the upper body, I should put 2 gland shunts, one on each SVC. So each SVC would be connected to its corresponding pulmonary artery, the left to the left and the right to the right. In cases of interrupted IVC, drainage of the lower body is through the azygos vein or hemizygous vein to the superior vena cava. So the gland shunt physiology resembles the Fontan shunt and is termed a Kawashima procedure. So a Kawashima procedure is a gland procedure, is a superior cavopulmonary anastomosis, but in a case of interrupted IVC. Fontan completion procedure may nevertheless be needed later to direct the hepatic drainage to the pulmonary artery to prevent the Fontan pathology. We'll talk about this later. Intraoperatively, arterial line in the radial artery on the side of the MPT shunt is not preferred, as we said before, because it is usually damped. Lower limb lower limb superior lower limb central line. Avoid upper body central line to prevent the thrombosis of the glen shunt. So we should not insert a central line in the upper body. Internal jugular vein cannula may be needed for pulmonary artery monitoring post bypass, just to measure the glen pressure, and then we remove the catheter. And we try to insert a small caliper catheter to decrease the trauma caused by the catheter, but to be removed as soon as possible and not to be used for any infusions, especially blood and antibiotics. If redo, we prepare packed RBCs in the OR, defibrillator pads, wide bore IV, and tranexamic acid infusion. This is glen circulation. So the blood is pumped from the left side to the body. And then the blood is pumped to the brain, to the upper body, and the rest of the body. The blood coming from the lower limbs is pumped to the right side of the heart as normal, but blood returning from the brain would pass directly into the pulmonary circulation, and this is the only blood supply to the pulmonary circulation through the glen shunt. Post-operative, ensure low pulmonary vascular resistance by tracheal suctioning, recruitment of the lungs, check the PCO2 around normal, or with no less, because low PCO2 decreases brain perfusion, so the systemic, the superior vena cava venous return. This is the cavo pulmonary cerebral circulation. So if the PCO2 decreases, the blood flow to the brain decreases, so the venous return to the lung decreases, so the patient becomes cyanotic. So it is important to keep the cerebral perfusion and not to decrease it. A good tidal volume with low respiratory rate, with high expiratory time and low PEEP. Check good oxygenation, avoid acidosis, hypothermia, and hypoglycemia. This avoids increasing the pulmonary vascular resistance. Good analgesia and anesthesia. Myrindone may be needed to decrease pulmonary vascular resistance. Good hydration, head up position, neutral head position, because a head that is extended too much to the right or to the left may compromise the neck vessels. MUF is beneficial. Desaturation may be due to high pulmonary vascular resistance, pulmonary stenosis, ventricular stiffness, unanticipated collateral from the superior vena cava to IVC or coronary sinus. This collateral may drain the glen to the lower body rather than to the lungs. So the patient becomes cyanotic. High pulmonary artery pressure may be due to volume overload. So compare the glen pressure with the femoral vein pressure. If the femoral vein pressure is high, so maybe the patient is overloaded. But if the femoral vein pressure is not high and the glen pressure is high, so this is pulmonary artery, pulmonary vascular resistance is high. If both are equal, then the patient is overloaded. If the glen pressure is higher, measure difference between the glen pressure at the superior vena cava and the pulmonary artery. If the superior vena cava pressure is higher, then the surgeon should revise the anastomosis. So in this case, if the superior vena cava pressure is higher than the pulmonary artery pressure, so there is a gradient across the suturing of the gland. So the anastomosis should be revised. If they are equal, then the pulmonary vascular resistance is high. So if the pressure is high in the catheter that is inserted in the internal jugular vein, so I should compare this pressure in the superior vena cava with the femoral. If they are equal, so the patient is overloaded. If the SVC pressure is higher, so I compare the SVC pressure with the pulmonary artery pressure. If there is a gradient across, then the sutures should be revised. If they are equal, then there is pulmonary vascular resistance that is high. And finally, Fontan completion, or the inferior cavo pulmonary completion anastomosis. Preoperative, a hemodynamic study is done in the cath lab to check the pulmonary artery pressures. Ideally should be less than 16. The pulmonary vascular resistance. Check the saturation, check the hematocrit level, ensure good hydration to avoid desaturation and thromboembolic events. Surgery, there are two procedures, the lateral tunnel Fontan and the extracardiac Fontan. In the lateral tunnel Fontan, we do a tunnel, we take the inferior vena cava and pass it through with a Dacron tube or a pericardial patch in the form of a tube that passes through the right atrium to the pulmonaries. And this is the extracardiac. It is a synthetic graft that is outside the heart, shunting the IVC to the pulmonaries. In the lateral tunnel, we need a bypass and aorta cross clamp. The tunnel is a prosthetic tube inside the right atrium. Fenestrations may be done to the common atrium to decompress the system if the pulmonary vascular resistance is high. So to decompress the pressure in the Fontan. It is not preferred, however, because of incidence of atrial arrhythmias later. SVC and IVC flow collision in the atrium, and the fenestrations cause some desaturation and paradoxical emboli. So now we prefer the extracardiac. It needs bypass but without cross clamp. The prosthetic tube is connected to the right pulmonary artery, not opposite to the superior vena cava, to avoid collision of flow and allow streamlined dynamics. So unlike this diagram, the sutures are done either proximally or distally, so that the two anastomoses are not opposing each other like this, because blood flowing from the lower body and from the upper body would collide here, causing turbulence, and that may render the glen or the Fontan with a high pressure may not be that effective. So they should not. One of them should be face. Usually the right would face the right pulmonary artery, and the left, and the Fontan would face the left pulmonary artery. Hepatic blood is excluded, so Fontan pathology may occur. Fenestrations may be done if the tube is adherent to the or is fixed to the right atrium. We may do some fenestrations. Sometimes the hepatic vein can be included in the Fontan. This is the fenestration of an intracardiac Fontan. Intraoperative, we plan for early extubation by reducing opioids. We use non-opioid analgesia and nerve blocks, because an early extubation avoids the positive pressure effect of the ventilator on the pulmonary vascular resistance. So a negative pressure in the chest would be preferred to suck the blood from the lower body through the Fontan to the lungs. Arterial line in the radial that is on the side of the of a previous MBT shunt may be damped, as we have said before. Lower limb CVP, we avoid upper body central venous line to prevent the thrombosis of the Glenn shunt. An additional benefit of the femoral central line is that if bleeding occurs, these cases are usually redo cases. So if bleeding occurs during sternotomy of a redo patient, blood infusion passes directly to the aorta through the femoral central line without loss in the field if upper body IV access is used. So if bleeding occurs with injury of the Glenn, if I give blood from the upper body, even from a upper body central line, or even if a peripheral cannula in the hand, so blood used in resuscitation may come out of the Glenn or of the injury. But if I give blood through the femoral or through the lower body in general, blood passes directly to the aorta with the risk of embolization. So we should be careful in these cases. Internal jugular vein cannula may be needed for pulmonary artery monitoring post-bypass, but to be removed as soon as possible and not to be used for any infusions. It's a case of redo. We should keep blood in OR, defibrillator pads, white bore IV, and tranexamic acid infusion. Post-operative, ensure low pulmonary vascular resistance by tracheal suctioning, recruitment, good tidal volume with low respiratory rate, high expiratory time and low PEEP. Early extubation, and spontaneous ventilation are preferred to create negative intrathoracic pressure to pull blood from the IVC. Check good oxygenation, avoid reasons that may increase pulmonary vascular resistance, avoid acidosis, hypothermia, hypoglycemia, good analgesia and anesthesia. Merinone may be needed. Low cardiac output may be due to obstructed Fontan, because in these cases, if there is high pulmonary vascular resistance, the entire venous return of the body may get obstructed, may stagnate, and this decreases the venous return to the heart, to the single ventricle, and so the cardiac output to the aorta would decrease, causing heart failure, congestive heart failure. So an obstructive Glenn would cause desaturation, but an obstructive Fontan would cause low cardiac output. So an obstructed Fontan, high pulmonary vascular resistance, hypovolemia, poor single ventricle function. So we should support this single ventricle, because this single ventricle is pushing blood through two circulations, the systemic and then the pulmonary, without another pump in between. Aortic valve regurg, pulmonary artery stenosis, all these may cause low cardiac output. Low cardiac output may be difficult to detect and may present as desaturation if fenestrations are present. So if the pressure rises in the Fontan, blood may flow from right to left, or from the Fontan to the heart, causing desaturation. This is a normal circulation. Blood is pumped through the left ventricle and then pumped again by the right ventricle. But in these cases, blood is pumped only once, and then it flows by gravity or by just inertia from the aorta to the central venous pressure to the pulmonary artery, to the vena cava to the pulmonary artery, and then it's pumped again through the single ventricle. You can also notice that the venous pressure does not fall to the right atrial pressures that you are used to. We are used to right atrial pressures normally of around 5, maybe 0 or subatmospheric. but in these cases the pressure is usually around 15 or 16. Late sequelae. Later in life, low cardiac output symptoms may develop, as we have said before, for these reasons. Arrhythmias may occur. Thromboembolic events may occur due to the sluggish circulation with high venous pressure and the presence of synthetic tubes in a venous system. All these may cause thromboembolic events. Protein losing enteropathy of unknown cause. Plastic bronchitis, rare but serious and of unknown cause. Proteinaceous casts in the tracheobronchial tree, resulting in chronic cough, wheezes, dyspnea, and hypoxia. Pulmonary AV malformations caused by right to left shunt and desaturation, attributed to a hypothetical hepatic factor that is produced in the liver and must pass the lung to avoid this pathology. So this pathology develops when blood coming from the liver does not pass through the lungs. So if I do an extracardiac Fontan and I exclude the hepatic venous return of the liver and allow it to pass to the right atrium and then directly to the aorta through the single ventricle, so blood from the liver does not pass through the lungs. In these cases, the AV malformations develop. So, a hypothetical substance that is called the hepatic factor is assumed to be present, and this factor is assumed to protect the lungs from the AV malformation, that it keeps them closed. So if this substance does not pass the lung, and it bypasses the lung directly to the aorta, in these cases AV malformations develop. These late sequelae are collectively called the Fontan pathology, and the Fontan pathology is fatal and sometimes irreversible, even with a heart transplant. So it is better to avoid the Fontan pathology as much as possible. So going back to this algorithm, we start at birth with a saturation of 85%. If higher, we do a pulmonary artery band. If lower, we do an MBT shunt or a PDA stent. And then at the milestone of sitting, we do a Glenn procedure. And then later, during adolescence, we do a Fontan procedure. Why does the patient desaturates with the growth spurt? Because the proportionate the venous return from the upper body in infants is around 60 to 70% from the superior vena cava, because these patients have larger heads and larger upper body compared with the lower body. So the venous return from the lower body is small compared to the venous return from the upper body. So a Glenn procedure is enough to perfuse the lungs with enough venous return. But with the growth spurt, the proportions are reversed. So the lower body comprises around 60 to 70% of the venous return, and the head and the arms, the upper body comprises only 30% of the venous return. So the more the patient gets taller and grows, the more the patient desaturates, up to a saturation that is intolerable. In this case, Fontan is indicated. So why don't we do a Fontan procedure from the start, at 6 months? Why do we wait till a case of desaturation, and then the patient is exposed to another open heart surgery that is a redo with a high risk? So why don't we do a Fontan operation from the start? The answer is because after the Fontan procedure, we wait for like 30 to 40 years for the Fontan pathology to develop. So if I do a Fontan operation at the age of 6 months, so these patients may develop Fontan pathology earlier. So I delay Fontan as much as possible, and if I avoid it altogether is better. So I try to avoid Fontan procedure, and if I must do it, I do it at a later age, so that the Fontan pathology develops as late as possible. Thank you very much. We'll continue in the next part.